So our next and first speaker this morning is Dr. Sarah O'Brien. She's an assistant professor of pediatrics in the Division of Hematology and Oncology at The Ohio State University. She's an investigator there, attached to the Center for Innovation in Pediatric Practice at Nationwide Children's Hospital. Her interests include pediatric thrombosis and thromboprophylaxis and the intersections between hematology and women's health. She's been a real star in women's bleeding, or young women's bleeding and clotting issues, and we're very glad to have her as a medical advisor for our organization and to speak to us this morning on managing heavy menstrual bleeding in women on anticoagulants. Thanks, Sarah.
Good morning, thank you. It's my pleasure to be here today. I definitely left a lot of room for questions and I hope discussion in my talk, because I see myself as more of a facilitator than an expert on this topic, and I also think that, one, there's a shockingly scant amount of information in the literature to review for all of you on this topic, and two, I know that my perspective as a pediatric hematologist is different from adult hematology and OBGYN, and I'm really looking forward to hearing what other folks are doing with some of these unanswered questions in the field. So I thought I'd wrap my talk today around a patient vignette. And those of us in pediatric hematology, this is a very common story for us. So a 16-year-old female, we'll call her AC, has been started on oral contraceptives for management of abnormal uterine bleeding. 4 months later, she presents to the emergency department with chest pain and shortness of breath and is subsequently diagnosed with a pulmonary embolism. She is admitted to the hematology service. Her oral contraceptive is immediately discontinued, and she is started on low molecular weight heparin overnight. You and your team round on her the following day and talk to AC and her parents about the treatment options that are available. Your children's hospital happens to be a site for the phase 3 Rivaroxaban study, and after taking a few of the low molecular weight heparin injections, they're very interested in this possibility. So they enroll in the study, and you find out later that day that she has been randomized to receive Rivaroxaban. So the first question that comes to mind is, so what is the likelihood that our patient or any woman will experience heavy menstrual bleeding while receiving anticoagulation? So even for an agent that we've been using for decades, vitamin K antagonists, it's really amazing how little information has been published. So there are several small studies, all retrospective, and when you look at these together, it seems that the range of heavy menses can go from 22 to 65%, depending on the study. But I think those numbers are hard to interpret because we all know that heavy menses is very common in the general population. So what's the difference between the general population of women and women on warfarin? There was one study, it was still a retrospective study, but they did try to do a pre and post look at this, and they determined that the prevalence of heavy menses increased from 44% before starting warfarin to 71% while taking warfarin in this patient population. Grouping these studies together, you can see that women complain of a variety of problems, whether it's that the anticoagulation increased the number of days of their menses, increased flooding, increased the passage of large clots, or perhaps breakthrough bleeding became more of a problem for them. I know that on the adult side, you don't often use low molecular weight heparin as your long-term therapy for the treatment of thrombosis, but we do more in pediatrics, so we even do have adolescent females who may elect to do low molecular weight heparin for 3 to 6 months. And we do not have any information published on what the incidence of heavy menses might be in this patient population. So now I'll move on to the direct oral anticoagulants. And we'll start with Rivaroxaban. And there has been a post hoc analysis performed from the Einstein study that found that heavy menses did occur more frequently, actually, in women taking Rivaroxaban as compared to warfarin. 31% in the Rivaroxaban group compared to 13% in the warfarin group. There's also a much smaller observational study that again showed a fairly high incidence of mucosal bleeding, the great majority of which was uterine bleeding in women using Rivaroxaban for treatment of VTE. When we look at apixaban, there's again been a post hoc analysis. This is a cohort from their Amplify study where they looked at clinically relevant non-major vaginal bleeding and found that actually the groups were similar with an incidence of about 2% in each group. So I think we've already stumbled upon one of the other problems in this literature, which is how do we define heavy menstrual bleeding and how are we collecting the information on that adverse event? Because to me, at least, it doesn't make any sense that women taking warfarin in the Amplify study would have a 2% chance of heavy menstrual bleeding. But if you're taking the same medication in the Einstein study, your chance of heavy menstrual bleeding is 13%. So obviously, there's different definitions, different strategies or vigorous nature of collecting this data. For edoxaban, we have very little information. I found one study with about 300 people total that looked like the incidence was pretty similar between edoxaban as compared to primarily warfarin was the standard comparator group there. So moving from the direct anti-10A drugs to the direct thrombin inhibitor Dabigatran, we have a post hoc analysis of about 1,200 women from the several pooled studies in this area. And these trials actually reported a significantly lower rate of abnormal uterine bleeding in women treated with Dabigatran as compared to warfarin. So you can see the numbers were 6% with Dabigatran compared to 9.5% with warfarin. So I think to summarize the DOAC literature, we don't have a lot of information. There are definitely weaknesses in the study design. And I think also, like for example, the Rivaroxaban study included all women under 60. We know that probably not all of those women were menstruating at the time that they were on the Einstein study. So just the problems with post hoc analyses. But I think what we know so far suggests that when you compare these agents to warfarin, the risk of abnormal uterine bleeding may be higher with Rivaroxaban, appears to be about the same with apixaban and edoxaban, but perhaps is less with Dabigatran. So back to our patient AC. So for about 4 weeks later, your Rivaroxaban study coordinator stops by your office, and she just completed her day 28 telephone study visit with the mother of patient AC. So AC has started her menses for the first time since being on the study, and she is not happy. She is changing overnight pads about every 3 to 4 hours and passing quarter-sized clots, and says this is exactly why she had started her oral contraceptive. It was working great, and she wants to go back on it. So what are the different strategies that we have to address AC's heavy menstrual bleeding? So first, I'm a hematologist. Many of us are hematologists. We love checking labs. So first, what initial laboratory studies might you consider in this situation? So actually, for this situation, I don't think I would check any labs today. The bleeding doesn't sound severe enough to me, or it hasn't been going on long enough that I feel the need to send AC to urgent care or an emergency room to check what her hemoglobin is. I have the study coordinator review signs and symptoms of anemia with her, and it doesn't seem like any of those are going on right now. And I don't also see the need to check a level. That's not what we clinically do typically for our patients on DOACs. But there are some situations where you might consider checking a lab at this time. So certainly if AC was taking warfarin or low molecular weight heparin, I probably would check a level just to make sure that super therapeutic anticoagulation isn't contributing to the problem here. And I think also just in my personal experience, I find a lot of times that adolescents on low molecular weight heparin, their anti-10As tend to creep up once they leave the hospital. So I don't know if that's a difference in metabolism as they're starting to feel better or what that's about, but I routinely see that in practice. Again, for a patient on a DOAC, we typically wouldn't consider checking a level. Many of us don't have levels available at our institution to be able to check. But I think if I had a medically complicated patient who was on many medications, maybe some that also could affect renal function, or an elderly patient, for example, I think you would think about whether their renal status may have changed, and perhaps that could cause them to have supratherapeutic anticoagulation. And then, of course, the question, should her OCP have been discontinued at the time of admission? And I always think in this patient scenario, for all the things that the residents forget to do about our patients, they never forget to stop the oral contraceptive. It's like the very first thing that happens. And so by the time you get there the next day, it's kind of already said and done. And certainly we know that early discontinuation of contraception exposes our patients to the risk of an unplanned pregnancy. And unplanned pregnancies in a woman on anticoagulation are even more complicated because these agents do cross the placenta. And I also think that people forget sometimes that many women are using these agents not just for contraception, but for abnormal uterine bleeding. So you're kind of giving them a double whammy, right? You're taking away a medication that has helped their bleeding and giving them a new medication that has a risk of bleeding. So what do our guidelines recommend? So unfortunately, it depends on which guideline you choose to look at. The World Health Organization, which I think many of us use as our go-to when we're making decisions about contraceptive safety, states that having an established VTE on anticoagulant therapy is a condition that represents an unacceptable health risk for combined hormonal contraception when used for contraceptive purposes. That's a pretty strong statement. They do have a statement to the side that's not quite in that bold, not in that bold language, but that says that hormonal contraception use for therapeutic purposes in the event of acute hemorrhage or hemorrhagic ovarian cysts, I think, or severe menorrhagia is how it's worded, severe menorrhagia or hemorrhagic ovarian cysts, then the risk-benefit ratio would change, and you can consider that on a case-by-case basis. The ISTH guidelines are a little more liberal, suggesting that hormonal therapy can be continued in selected patients after initiation of anticoagulants. But I would imagine that for somebody who doesn't do this every day for a living, if I were just looking at these guidelines, I would stop the OCP when they were in the emergency room as well. They're pretty conservative. So then let's think about what is the risk of recurrent VTE in users of hormonal therapy during anticoagulation. And again, this is an area that really just needs a lot more information out there. So back to that Einstein PE study, which included about 2,000 women. They looked at women receiving hormonal therapy, which was about, I think almost 500 of them were receiving hormonal therapy while on the study. And over 300 of those were receiving an estrogen-containing agent. So there was estrogen and progestin only to look at. So those using hormonal therapy while on anticoagulation had a risk of recurrent VTE comparable to women not using hormonal therapy. So certainly this is very reassuring information, but we need more studies like this, I think. With lack of other information specific to our patient population, I think we can also just remind ourselves of the general population when making decisions in this area. So we know, I'm making broad generalities in this slide, but we know that in general, using a combined estrogen-containing pill, such as AC is on, increases your risk of VTE about 4-fold. Studies suggest that Depo-Provera may lead to an increased risk of about 2-fold for VTE. And on the other hand, we have lots of reassuring data in women in the general population, as well as women at risk of or with past history of thrombosis, showing that progestin-only intrauterine devices appear to be a great and safe choice for this patient population. So I think that in my opinion at least, outside of the IUD, in this setting, you would want to make sure the patient is on adequate anticoagulation therapy in order to safely use these other hormonal contraceptive agents due to the increased risk of VTE. I wanted to spend one more minute on IUDs because I do think they're such a great choice for this patient population, and I talk about it with my patients a lot. And there was also happened to be a study in women on anticoagulation, a small study, but showing that the use of the IUD as compared to the control group did decrease PBAC scores for women receiving anticoagulation. But IUDs are not something that can be placed at a moment's notice for our patients, especially in the pediatric realm. We need to consult. Many of our patients are not sexually active. Many of our patients require sedation before having IUDs placed, and so it takes time to be able to use that therapeutic strategy. I spoke about the hormonal agents. I wanted to touch a minute on tranexamic acid, which of course was hotly discussed yesterday evening in several of the talks. So last night I almost was like, I just want to delete the tranexamic acid slides so I don't get a question, but I'll be brave and just keep them up there. So I think this is another option, using tranexamic acid during the menses itself. Dosing, of course, and formulations are a bit different in different parts of the world, but that can be a good treatment option for our families. And I think especially, I just had this conversation with a family yesterday. She's experiencing heavy menstrual bleeding, but she's already done with 6 weeks of her therapy. She only has 6 more weeks of anticoagulation to go. She doesn't really want to rock the boat and start a new daily medication, and so we talked a lot about tranexamic acid as something to just kind of get us through until she's done with her apixaban. She's on a apixaban study. But what about tranexamic acid and VTE risk? So we don't have information specifically on women with VTE using this medication, and of course we have label warnings and black boxes from the FDA that make it very scary to use this medication. But in my opinion, the thrombotic risk in this patient population has not been confirmed. We do have small case control studies in women using this agent for heavy menses that has not shown an association with VTE. And this statement is broad, and we discussed it yesterday, but in general, I think that our studies on tranexamic acid use with trauma and surgeries does not clearly show an increased risk of thrombosis. So we've talked about what we can do in terms of using agents to try to adding on agents to decrease the heavy menstrual bleeding, but what can we do in terms of the anticoagulant itself? I think for our patient, we don't have a lot of options. She's on a clinical trial and prefers to stay on the clinical trial because she really likes taking the oral anticoagulant medication. She's only 4 weeks out from her VTE, so I would not be comfortable adjusting down her dose of anticoagulant at all. And certainly I wanted to make clear that I'm not focused on emergent management in this talk. If somebody's coming in with severe acute hemorrhage with hemodynamic instability, of course you need to withhold the anticoagulant they're on, and in some cases even consider reversal agents. For patients who are very newly diagnosed with their VTE, or perhaps those with antiphospholipid syndrome that you're particularly worried about VTE recurrence, you can consider lower dose, low molecular weight heparin while you're trying to get through this and stabilize the patient. But I'm going to be focusing on more of that outpatient chronic heavy menses setting. So I keep looking for this abstract to be published as a manuscript because I'm curious to see it in peer-reviewed format. But there was a study presented at ISTH in 2017 from the Einstein Choice trial suggesting that using 10 milligrams of Rivaroxaban can decrease menstrual bleeding without increasing the risk of thrombosis when comparing it to the traditional 20 milligram dose. This slide is from, I had the honor of being kind of the pediatric voice on a review article on this topic, and was working with some adult physicians at McMaster. So these are strategies that they're using at McMaster for their patients. None of these are evidence-based at all. So one of the things that they will do is just during the menses, they will reduce patients' Rivaroxaban dose from 20 down to 10. They'll reduce apixaban from 5 milligrams twice a day to 2.5 milligrams twice a day, again, just during menses. For some women who are even farther along in their anticoagulant, perhaps those on lifelong anticoagulation, who they view as being at lower risk of VTE recurrence for whatever reason, they may do these lower dosing on an everyday basis. But again, you'll see these are all women that have been on anticoagulation for at least 3 months. And again, we don't have any studies looking at the success or risks of these strategies. You could also consider switching to an alternative anticoagulant. I didn't put warfarin on the list because in my experience, that's a really difficult sell once somebody is using one of the DOAC agents. But I think this slide is just to remind you of the different risks of heavy menstrual bleeding as compared to warfarin with these different agents. So I think it would be very reasonable if your patient is on Rivaroxaban and otherwise tolerating it well, they may do better on apixaban or Dabigatran in terms of their heavy menstrual bleeding. And again, I think this makes more sense for women who are going to be on these agents for longer term. I think for those of us in pediatrics, if we have someone who's just going to be on this agent for 3 months, you're less likely to want to change an agent halfway through, for example. I wanted to wrap up my portion of the discussion by talking about current practice patterns. And again, I really want to hear from you regarding your current practice patterns. This was a study looking at both expert opinion and an international survey of a few hundred clinicians. So they talked to 10 people that were the thrombosis experts, 10 people that were abnormal uterine bleeding experts, and then the survey was sent out fairly broadly to interest groups. So what would these physicians do for our patient? Well, it depends on which ones you asked. This sounds like a toothpaste commercial, but 7 out of 10 of the thrombosis experts felt comfortable if a patient was on oral contraceptives, continuing that oral contraceptive throughout their anticoagulation and only considering discontinuation and discontinuing the estrogen at the time of the planned anticoagulation discontinuation. In contrast, when you talked to the abnormal uterine bleeding experts or the clinician survey, half of them recommended discontinuing the OCP at the time of VTE diagnosis. And certainly I think that's what I see happening in practice at my own institution. This slide is really just to show you the colors, that there's difference in opinion between the thrombosis experts in blue, the menstrual bleeding experts in yellow, and the international survey in green. The top row of this is looking at women in that first month of anticoagulation, and the bottom row is looking at women after the first month of anticoagulation. So certainly the text is very hard to read. So what I want you to focus on is when you're looking at row B, the second one over, that's temporary holding of anticoagulation. So the thrombosis experts are much more comfortable holding anticoagulation. I'm horrible with pointers. Which one is it? It's the red. This one is showing that the thrombosis experts are more comfortable with holding anticoagulation than the abnormal uterine bleeding or the international survey. The other thing, like any good thrombosis expert, they say no to IVC filter use in these patients in either setting. The other respondents were a little bit more likely, but still not many people were comfortable with that either. And I think the other difference that I thought was notable was with tranexamic acid, and again showing that people who are not necessarily experts in the field are less comfortable using tranexamic acid for these patients than the experts are. They did come up with 4 consensus statements out of this paper. The first one I was surprised given the answers of the survey, but in the end they decided that hormonal contraception was not judged to be a risk factor for recurrent VTE during anticoagulation treatment. For patients who want to start contraception during anticoagulant therapy, progestin-only pill and progestin-releasing IUDs were suggested as the best options. Tranexamic acid was suggested as an option for treatment of HMB in this setting, and reducing the dose of anticoagulation, stopping anticoagulation, or using IVC filters were not recommended, especially in that first month of anticoagulation. But actually, what I thought was most interesting about this study, and I think really brings home the point of the importance of this foundation, is that 2/3 of the respondents to this survey were non-hematologists. And it just and they came from such a wide variety of specialties. And it really reflects how many different types of physicians take care of women in this situation. And so it just highlights that not only do we need more research in this area, but when this research is completed, dissemination is challenging because we need to communicate these findings and recommendations to a very wide audience. So what happened with our patient? We brought her in later that week. She was still bleeding heavily. I did check a lab then that she was non-anemic. She's otherwise tolerating the Rivaroxaban well. As I mentioned before, she really appreciates the once daily dosing. She has a play she's practicing in for school, and taking medications in the evening is very challenging for her, so she doesn't think she can do that. And she really doesn't want to go back to the shots. So we elect to continue her on the study, continue Rivaroxaban, and restart her OCP. And at that point, I would probably refer her to one of my pediatric gynecology colleagues to talk about what are the long-term progestin-only options, preferably something like an IUD that she can use when she's done with her anticoagulation. And her heavy menstrual bleeding resolves over the next 48 to 72 hours and doesn't recur during the rest of her time on Rivaroxaban. So I'd like to thank you for your attention this morning, and I am looking forward to hearing the discussion today. Thanks.
That was an illuminating talk, an observation. At the present time, I think the Wall Street Journal reported that Janssen Pharmaceuticals has about $760 million in outstanding legal actions regarding Rivaroxaban. Second observation is that in men, where the studies are often conducted, there's a 5-fold difference, at least, in the response of men's blood to tissue factor, which probably is relevant to dosing. But as you know, there's no dosing decisions associated with these anticoagulants. And the reason, I was an advisor to most of the companies that make these things, and that decision of no need for analysis or dosing was made before any biochemistry was done. It was a marketing decision. So I think the reality is that we have to have ways at some point in time to look at the dosing of anticoagulants of any sort with respect to the individual and not the population. So that's just an observation.
Thank you.
Hey, sir, thank you. Excellent presentation as usual. I just wanted to give you 2 more scenarios about your patient. So a year later, she's on Mirena primarily she's off, she's off anticoagulation. She's on Mirena for contraception, and she develops painful cysts and ovarian cysts. So she needs to go off. That's, reason I would think. And let's say she's throwing some spotting. She really can't have, let's say she expels it. So at that point, would you consider perhaps a second generation OC that has levonorgestrel because we think it's, less, it's really has an anticoagulant effect with perhaps low-dose River, or do you think there'll be any role later in considering that? And then as a parallel situation, you talk about your house staff doing things, they don't listen to you. Well, they're going to also do a thrombophilia workup. So they discover she has factor V Leiden, and then
That happened in the ER also,
and then
yes.
the cousin now gets tested and is referred to you, and she wants to stay on. She's sexually active. She's doing well on OC. She wants to stay on COC. So in that setting, would you ever think, similar to what we do with women who've had a hormonal-related VTE who are now pregnant, of thinking of low-dose anticoagulation? Would that be a role for 2.5 BID of Eliquis or 10 of Xarelto?
But have you been in my clinic? I feel like you're saying, that was so many questions at once. So I think that, so for the one we do see a lot, the factor V Leiden and then relatives coming in. I mean, there's not a right answer to these questions, right? This is just what I do. So in that situation, I usually consider how long the sister has been on the oral contraceptive. And if she's been on the oral contraceptive for more than a year without any difficulties, I think her risk of developing a clot is much lower. I also look to see what oral contraceptive is she on. So for example, if she's on something from the Yaz family, I would probably suggest switching to, making sure that they're on the safest form of the oral contraceptive. And that's how I approach it. But I think that and I have a few patients, and I think you probably see this much more in adults, but I do have a few patients where we decide that they really need to be on estrogen for some reason. So I have some patients that, due to cancer therapy, they have premature ovarian failure, for example. And so I do use estrogen with those patients, and I do prophylactic DOACs with those patients.
Would a transdermal be safe? I thought you could do transdermal even in thrombophilic patients based on data Mary Cushman's.
And some of my endocrine colleagues do that, but that's just what, that's not one that I'm as familiar with in my practice.
But going back to this case, what if she does years later want to go back on estrogen? What would you do?
Mm-hmm.
Would you not offer it, or would you do concurrent Xarelto or a different prep?
I think with the information we have now, I would not be comfortable with her on estrogen without also being on low-dose anticoagulation.
Low dose would be okay.
Yeah.
Okay.
Thank you. Let's say 5% of pre-adolescents have ADD.
Mm-hmm.
Let's say 90% of adolescents have ADD. They're flakes. They're non-compliant. And so I'm really wondering how many times people on Rivaroxaban actually take it once a day. Mm-hmm. And I really wonder how many times adolescents that are on apixaban take it twice a day. And compliance, based on numerous factors, mainly just being a ditz, is not something that we consider, or that we haven't considered in this forum. It's a big deal. So, and the other component is, and I've seen this in our clinic, and that is where the subject becomes their own hematologist. Mm-hmm. And their usual decision is, when they start having heavy menstrual bleeding, they just stop it. So there's lots, I think, of young women who, when they're on anticoagulants and they're bleeding heavily, they just stop it, and it goes away. And then when they're better, they start it again. So far, we've not had any problems with that, but that's just something to point out. With regard to the very, very critical early 4 to 12 weeks post-event, and maybe I'm just too conservative, but that period of time really scares me. Mm-hmm. And the compliance issue is not necessarily determined by risk to life, some people walk out and forget to pick up their Rivaroxaban prescription or decide not to for 2 or 3 weeks. Or the drugstore was closed and I'll do it tomorrow, and then they forget. So I wonder in this high-risk period whether Lupron or Grosserolin should be considered for the first 3 months. In other words, ovulatory, complete ovulatory suppression, just for that a month's period of time. Then the other thing is the issue of the tranexamic acid. Physiologically, I just don't feel that you can take a prothrombotic drug, clearly a prothrombotic drug, and give it to somebody that's had a thrombosis. It makes just no physiologic sense to me. Don't confuse me with data. But I'm wondering, would it be of value to use it the least dose that will cause fibrinolytic blockade, at least as far as we can measure it? Could you just use the dose until you get a negative dimer and not base it on more is better? I mean, how much fibrinolytic inhibition can you have? If you take Lysteta 6 a day, maybe you only need 3 a day to get dimer negativity.
I don't know about dimer negativity, but certainly in the initial tranexamic acid studies in adults, using it twice a day also helped. The final dosing ended up being 3 times a day because it worked a little bit better. But I think you're right, for a patient like this, it might be very reasonable to try to get away with twice daily to see if you can get symptom control. And I think that your point is important, and all of this is in the context of a person taking therapeutic anticoagulation and taking it consistently. So it's an individual, that's why it has to be an individual decision for each patient based on compliance and family understanding and all sorts of factors.
So in light of that, my comments are going to sound considerably more controversial than they were a minute ago. I actually wanted to applaud you for talking about using tranexamic acid and OCPs in this setting, because we actually do have data that show that women do hold their anticoagulants for periods of time, and even 2 or 3 days of holding will increase the risk of VTE as much as 5-fold. So I think that we do need to be really practical and not get as ivory tower as sometimes we do, thinking about what's actually going to happen in the real world. We can sound really great sending patients out off OCPs and on anticoagulation, and maybe if they're taking the anticoagulation, they don't have as much recurrent VTE, but in practicality, bad stuff happens anyway, and I do think we need to be aware of that. And I also think we need to be aware of the risk of pregnancy, right? We withhold this anticoagulant, we withhold the OCPs, and then just, I don't know what we assume the woman's going to do, but pregnancy is very risky in this scenario as well. Yes. And I know that progesterone-only pills are okay and safe, but I'm sure everybody in this room has seen a woman come in getting pregnant on progesterone-only pills, because they're really hard to take and they're really unreliable. And in light of that, I'm curious what you think about the subdermal implants. I know the data have, a 1.4-fold increase, but it's not statistically significant. And in light of the competing risk of pregnancy, I'm curious if you consider that an option.
So I think that there are good data that the implant is safe for women at increased risk of thrombosis. Our group did some work looking specifically at women with diabetes who are at higher risk, showing that those agents did not cause an increased risk of thrombosis. So from a thrombosis perspective, I feel comfortable with them. In peds, I think we see the scenario a lot more where they're coming into this with a history of abnormal uterine bleeding. And just in our experience, girls who have had abnormal uterine bleeding don't do well with those implants. So I'm hesitant to use I think they're great choices for somebody who wants great contraception and has normal periods, but just in our clinical experience, we've had a lot of difficulties with them, so they're not our first choice. I think one of the big challenges is just that life happens. You have this great conversation with the family about the progestin-only options, and then I just saw this week. She came back, and I was like, so how's the IUD going? Well, didn't get in. We forgot to call the gynecologist to make the appointment. Then we went in to see them, but they said since she wasn't having her period, it wasn't a good day to put it in. And, you know, I'm picturing my patient in her college dorm. Like, I was like, oh my gosh, like she's going to be pregnant. And it's just challenging to make these things happen as quickly as you want them to. And this patient was also an OCP, OCP, PE, and the OCP was stopped.
Just a question along those same lines with the Nexplanon implant. I'm curious, for women who are already on it and they've done well, and now you're starting an anticoagulant, how do they do? Are you still having to discontinue the implant because of abnormal bleeding?
I'll ask somebody from the adult world or gynecology to answer that. We use it. We don't have a lot of patients on the subcutaneous implant, so I personally haven't experienced that.
And then just one comment, because from a contraceptive standpoint, it's very clear that these long-acting reversible contraceptives are so much more useful, especially in young women. And so, you know, it's very important to build relationships between the hematology groups and the GYN groups to create clinics where women can just walk in and have on a single visit placement. They don't have to come back. They don't have to have a consult. That those single visits are clearly shown to improve.
And that's what we've been able to do with our group, is not just place a consult for a referral, but a consult that says IUD placement, so they know going in what to expect.
Right.
I agree, it's really important.
Hi, that was really great and extremely useful. I was wondering, had you run across anything in the literature about being sure to check women as they're getting older, perimenopausal, for polyps or for malignancy, hyperplasia? Because I've called Andy anecdotally, and of the couple patients I've had, about 50% have a malignancy, and the other 50% just had abnormal bleeding on their anticoagulant.
Yeah, I think, that's an important point with older patients, definitely. Is my experience similar to your experience, where OCPs are stopped immediately prior to discussion?
Yes.
I hear lots of
So the classic scenario, which we see less now that people are being started on DOACs rather than warfarin, is the patient will get stopped in the emergency room, and then she'll get bridged to warfarin, and then she comes in for a maternal fetal medicine consult for a warfarin exposure in pregnancy. That is just classic and frustrating, and was one of the impetuses for founding this organization.
So I think, and it's not always wrong to do that. I think I equate it to ITP in pediatrics, at least. It's very easy to give somebody IVIG. It's very difficult and to have a conversation with the family about what the different options are and to consider observations. I think it's kind of the same here. It's very easy to just stop it rather than considering the benefits and risks for that particular patient and talking to the family about it.
I just wanted to validate that this is exactly the experience that we have in our clinic too, and maybe a bridge of progestin-only pill to the next method would be, useful to consider when stopping estrogen. We still feel pretty uncomfortable using estrogen at all, even when anticoagulated, and we're sort of undergoing conversations about when do we think we'd individualize that. But my question is a little bit more about the subdermal implant. A lot of us have it now in our hospitals to be able to place immediately postpartum, and it is possible to have it placed immediately for many of these patients. But we don't really have data about immediate placement in this setting because there is such a big burst effect with the etonogestrel. I worry a little bit more about that early timing. So I'm currently not placing them immediately after VTE and waiting until the follow-up visit, at least until a couple weeks later. But that's an area where we probably need more data. We have a lot of postpartum data, and that's certainly reassuring, but I'm a little concerned still.
Thank you.
Hi, I'm Manila Gad from Atlanta, Georgia. I just have a comment. There is data with 10 milligram of Rivaroxaban and 2.5 twice a day of apixaban in adults after 6 months of anticoagulation in patients who need to go longer. So most of our patients, we are able to transition them to half the dose after 6 months. It's just the ones we are really worried about who are really hypercoagulables. They have an inflammatory bowel disease with a lot of flares, things like that, where we don't reduce. But otherwise, most patients, we are able to reduce them after 6 months.
Well, thank you for that wonderful talk. We really appreciate it.